Thanks everyone for coming by. Just to kind of introduce myself, I'm Alex. I'm a second year at the Melbourne Medical School at the Epworth Clinical Hospital. And I am also the preclinical lead for Teaching for Impact, which is an organization that uses education at the high school and also at the graduate medical student level to also simultaneously assist certain initiatives. And for this year, we are aiming to support the ASRC, the Asylum Seeker Resource Center. And just a few housekeeping things. In order to maintain decent connection throughout the presentation, please keep the camera and microphone off throughout the entire thing, unless of course you are asking and or answering questions. Not that I don't want to see your face, but just to ensure that we have a smooth and experience as possible. If you have a question, please pop them in the chat. I'll try my best to get to all of them, but if I can't, then I do have other members from Teaching for Impact here that may be able to answer your questions. But I will also take regular kind of intermissions throughout the presentation to ensure as many of those questions get answered. And whether or not you have to leave early or you got something to do, please be reassured that the lectures will be recorded and slides will be distributed as soon as possible. So this is just something for everyone that to say, but it's just that congratulations on making it through your MD experience thus far. I know it's a long, arduous journey, but ultimately you'll all rock this because you got this. So this is me, scrubbed up and stuff. Who am I? That's a question I ask myself pretty much every single day from when I wake up to when I go to bed. But that's not the point of this lecture. Just that I'm a Canadian, year 2 at Melbourne at Epworth so far. So I would like to first acknowledge the traditional owners of the land on which I present this revision lecture on today, the Wurundjeri people of the Kulin Nation, and I also acknowledge that any other traditional custodian groups that have looked after Australia, the country that I and other international students study and have made our home away from home. Firstly, I'd like to pay my respect to elders past, present, and emerging, and any Aboriginal and or Torres Strait Islander peoples that could be listening in today. And I acknowledge that this land is, always was, and always will be Aboriginal land. And welcome to the first set of preclinical revision lectures designed by Teaching for Impact. It will be delivered by me, Jason Dong, an MD3 at RMH, as well as honorary guest lecturers. And together we all hope to deliver the highest yield important topics with your preclinical education at the moment, as well as to get you all up to snuff with regards to the clinical years ahead of you through your respective experience. So with today's lecture on cardiology, going over some foundational science stuff and also use a case presentation to highlight some of these key topics so that you can tie everything together as we emphasize understanding rather than rote learning and memorizing. Again, feel free to ask questions either audially or with in the chat. And lastly, thank you, Dr. Victor Lin, our TFI president, as well as Sherry Shi, an MD3 at the Austin, as well as the treasurer for Teaching for Impact, for allowing me to inherit and modify the slides from previous years. So moving on. So this is starting off with the embryology or the heart development. So it is pretty much the first viscera that comes into fruition within the body through embryological development. And there are essentially 5 key parts throughout this development. That is, 1, the truncus arteriosus becomes the ascending aorta and pulmonary trunk. The bulbus cordis becomes the right ventricle. The primitive ventricle becomes the left ventricle. The primitive atrium becomes the anterior left and right atria, as well as their atrial auricles. And the sinus venosus becomes the posterior right and left atria or the SA nodes coronary sinus as well. So here's just some additional images showing more of the chronology of the embryological development of the heart. And you may be thinking, why am I starting off from, with embryology, as you may or may not have covered embryology either in your undergrad studies or with your current studies at the moment. Well, that's because cardiac or cardiovascular congenital heart diseases, they make up the most common congenital disorder in newborns. So for those of us who may be considering pediatrics or pediatric cardiology, this is something to kind of more or less, keep in mind. But essentially what defines a congenital heart disease is any malformation of the heart, the valves, and or the great vessels, which are present at birth. So now let's shift gears to a little bit of the anatomy of the heart. It consists of roots, so vascular roots of the great vessels enclosed within a sort of visceral sac, the pericardial sac or the pericardium, and which is attached to the central tendon of the diaphragm, which is important because you don't want your diaphragm to drop low to the ground. That's obviously a hyperbole, but essentially you only want the diaphragm to descend inferiorly just enough to facilitate that negative pressure respiration. There are three kind of openings or orifices that you can find in the diaphragm. The IVC, inferior vena cava, at T8, the esophagus at T10, and the aorta at T12. So the T refers to thoracic vertebral level. And a good mnemonic to keep that in mind in terms of the anatomy is I8, so IVC, T8, 10 eggs, T10, esophagus, if you spell that with an E the American way, at 12, aorta, T12. So the pericardium is two layers consisting of the outer fibrous pericardium and the inner serous pericardium, which is itself, the serous pericardium has two layers themselves, the parietal layer of the serous pericardium and the visceral layer of the serous pericardium. And the potential space between them is, as one can surmise, the pericardial space or the pericardial cavity. And normally the pericardial space is filled with just a small amount of pericardial fluid. But in certain pathologies, there could be increased fluid in this space, whether it can be from blood or something else. And this, what do you think would happen if that were the case? Would anyone like to venture an answer? So it's a condition which, if you fill that sac with fluid, it would obviously impede the heart's ability to contract and relax, which in turn impedes its natural ability to fill and eject fluid. So it's hemodynamically compromised. And the official term for that is cardiac tamponade. And now let's move on to other aspects of the anatomy of the heart. So the heart is kind of weird, is that it's kind of like a triangle that kind of faces this way, so to speak, where the base of the heart is actually superior and the apex or the peak of the heart is at the inferior aspect. Specifically, the apex of the heart would be located in the anterior chest wall on the left side of the body, specifically in the fifth intercostal space, mid-clavicular line, so kind of right here. If you were to do a cardiovascular examination and the apex beat were to be displaced laterally, what would that indicate? Yes, John, thank you. So left ventricular hypertrophy or just cardiomegaly in general. But the displacement can be due to other conditions such as pleural or pulmonary diseases, chest wall deformities, or just some weird involvement of the thoracic vertebra itself. So now let's look at the right heart. Essentially, the right heart is the primary aspect of the heart that's involved with the pulmonary circulation, as it receives blood from the superior vena cava superiorly and the inferior vena cava inferiorly, as well as the coronary sinus, which is a giant kind of vessel in the posterior top left of the heart. The superior vena cava has itself no valves, and it drains blood from structures obviously above the diaphragm. The inferior vena cava inferiorly has rudimentary valve, and it drains structures that are below the diaphragm. And the coronary sinus has no valve itself, and it just drains blood directly from the heart. So it's kind of like it's the heart's own inner kind of sewage system, so to speak. The posterior wall of the right atrium is smooth, is referred to as the sinus venarum, and the interior wall of the right atrium is lined by horizontal ridges called the musculi pectinati. The musculi pectinati can stop abruptly on the right at a vertical line called the crista terminalis. The crista terminalis is itself on the internal aspect of the interior wall of the right atrium. And the circus terminalis, which is not to be confused with that of your tongue, is on the external aspect of the interior wall of the right atrium. The SA node itself, if you want to think about the general anatomical area of the electrophysiology of the heart, is located just lateral between the junction of the superior vena cava and the right atrium, specifically in the sinus venarum at the horizontal level of the superior border of the sulcus terminalis. And the AV node is located on top of the coronary sinus at the horizontal level of the inferior border of the sulcus terminalis. The blood passes from the right atrium through the tricuspid valve into the right ventricle, and the internal aspect of the wall of the right ventricle is lined by ridges called trabeculae carnae. And just before the pulmonary valve, the wall itself of the right ventricle is smooth and is called the conus arteriosum or infundibulum, if you remember your anatomy lectures / workshops, if you're able to manage to go into them. And there are 3 trabeculae carnae that project into the center of the right ventricle, which are called the papillary muscles. These muscles are attached by cordon tendineae to the tricuspid valve. And obviously, if these chordae tendineae were to rupture or be damaged from one form or another, that could obviously lead to some valvular issues between the right atrium and the right ventricle. So now let's move on to some of the functional anatomy as well, the right heart. So the right ventricle, it would pump blood through the pulmonary artery. And as the blood gets oxygenated within the lungs and pumped back via the pulmonary vein into the left atrium, it then flows from the left atrium into the left ventricle via the mitral valve. The walls of the left ventricle themselves are also lined by trabeculae carnae, and 2 of them project into the center via papillary muscles. So you can already see that there is some distinction in the muscular infrastructure between the right and the left side. And that's because, the left side is the one that needs to do essentially more work as, a muscle, or I guess part of a muscle in this case. So what's clinically significant about this is that if the papillary muscle were to rupture, it is a common complication of myocardial infarction, aka heart attack, that occurs from 2 days to a full week after the infarction. And it can present with mitral regurgitation. So what does mitral regurg sound on auscultation if you're to do a cardio exam? So is it systolic? Is it diastolic? Is it soft? Is it loud? Are there extra heart sounds? Yeah, exactly. Pansystolic. It also kind of depends on whether it's chronic or acute as well. And does anyone know which kind of maneuvers would help to increase or decrease the intensity of a mitral regurg murmur if you want to distinguish it from something like aortic stenosis. Yep, leaning forward, breathing out would be the Valsalva maneuver, which would increase the intensity. You can also do it with the hand grip or squatting, because the thing you want to do is you want to increase peripheral vascular resistance to the ventricular ejection itself, which in turn would increase the intensity of the murmur. And conversely, to reduce the intensity of the murmur, you would, sorry, I said that the opposite way. So with the leaning forward, standing Valsalva, and the left lateral position would be, I believe, it would accentuate an aortic murmur. It would accentuate the extra S3 heart sound if there were to be a short rumbling mid-diastolic inflow murmur. And that's usually kind of in the case with a posterior leaflet prolapse of the tricuspid valve. So what can cause a mitral regurg? Well, there can be various reasons. It can be ischemia-induced damage of the papillary muscles. It can be infective endocarditis, which in turn would lead to damage of the chordae tendineae, acute rheumatic fever, acute dilation of the left ventricular, again, to secondary to myocarditis or myocardial ischemia, or just if there happens to be a mechanical valve or prosthetic mitral valve, if those valves were to expire. Because if you were to do a total replacement with a mechanical valve, they do have a limited lifespan. All right, so this is just what to think about with regards to patient presentation with acute onset right heart failure versus left heart failure. And with regards to heart failure, I will touch upon that later on. So is there any kind of questions or comments before we proceed? Excellent. So now we have a patient that is, I don't want to say typical, but common, is a moderately aged truck driver that presents with chest pain. So already, I just kind of want you to kind of think what's going on in your mind and what do you think, aside from cardiovascular causes, would be some causes for chest pain in general? Yep, pneumonia could be a pulmonary cause for sure. Yep, for a GI cause, trauma. Excellent, excellent, very good. You guys are on the ball. So basically, this is just a rough sketch table of the various kind of differential diagnoses for chest pain. I guess maybe because some of these answers are PM to me, that's probably why. But in case you missed that, one person mentioned pneumonia, another person mentioned gastroesophageal reflux disease, and another person mentioned like trauma itself. So the things that are bolded are the serious ones that are life-threatening and you do not want to miss. And the text in light green or lime green are those that are very special cases. They are unlikely to be a differential diagnosis for like an OSCE or whatever multiple choice question or other written assessments, but just something to, think about, I guess, as you progress through your medical education. So obviously the moneymaker here are the cardiovascular causes, is coronary ischemic syndromes. So those that can be further divided into stable angina and the three manifestations of ACS or acute coronary syndrome. Would anyone like to just briefly mention one or all of them if they feel comfortable of acute coronary syndromes. Yep, unstable angina, STEMI and non-STEMI. Very good, A. So another thing to consider is if there's an issue with the vessel, the aorta itself, an aortic dissection. So that's essentially when you get a tear within the tunica intima of the aorta, usually just superior to the aortic root or in the aortic arch, which can allow blood to enter into the actual space between the tunica intima and tunica media of the aorta, a false hole or lumen or cavity, if you will, which can present as a double barrel aorta. And the main risk factors for this are high blood pressure. If you were born with a bicuspid aortic valve, because semilunar valves are naturally tricuspid, or some connective tissue disorder like Marfan's or Ehlers-Danlos. It usually presents as a very severe, tearing, sudden onset chest pain that radiates to your back. And another thing to consider is pericarditis, which, as the name implies, it's inflammation of the pericardium. And it's the most common cause is by the Coxsackie virus, and that can present with a sharp pleuritic chest pain that is relieved by the whole Valsalva technique. Pulmonary, we'll probably go into a bit more detail when we talk about respiratory system in about a couple of weeks. But it's also an acute, sharp retrosternal pain that is also aggravated by deep inspiration. So why is there this pleuritic pain? What's the pathophysiology behind it? Or to give you all a hint, which of the pleura around the lungs has pain receptors? Yeah, somatic or visceral pleura. Very good. So when the visceral pleura, it's the parietal. It's not the visceral, it's the parietal pleura, because it's the parietal itself that is innervated by somatic nerves. And somatic nerves, which I guess you are correct, sorry, that's my mistake. Somatic nerves can sense pain specifically due to trauma and inflammation. And to think about it throughout the body, somatic nerves or somatic nociceptors are very good at localizing the pain. So if you were to have a somatic nociceptive stimulation, your brain will know exactly where on your body the pain is coming from. So pleuritic chest pain indicates inflammation of the parietal pleura. And when you inhale and as the lung expands, the two pleura, they contact and rub over each other, which exacerbates the pain. Pneumonia, in the case of infection, is another important cause, which for similar reason can lead to inflammation that triggers these nociceptors as well. A pulmonary embolism is definitely something you do not want to miss. Does anybody want to just provide like a sentence or two about what a pulmonary embolism involves and what's some risk factors? Yep, operation surgery can predispose someone to the predisposition to pulmonary embolism. Yep, oral contraceptives. So this all ties into the whole Virchow's triad of hypercoagulability, endothelial dysfunction within the actual vessels themselves, and prolonged stasis. So essentially what these all lead to is the increased likelihood of a clot, which if you recall, if you remember the whole clotting process, if a bunch of platelets were to somehow contact and touch each other at any moment in time, it could lead to a unwarranted clotting effect, clotting cascade to occur, which could be embolized elsewhere into the body and obviously cause some particularly nasty effects and presentations.
Metastases can also lead to some chest pain. But if you were to think metastasis, what would the patient also present with? Though this could be discussed further on in the next lecture. But if a patient were to have a metastasis, aside from some chest pain, what could they also present with? Yep, hemoptysis is a good one. Depending on the location of the metastasis, yes, that is also true. That is also a true statement. And with regards to, obviously, you don't want to miss a pneumothorax. So tall, thin male/basketball players, and also those with connective tissue disorders. If we were to, as a segue into GI causes of chest pain, a connective tissue disorder can also present with what other kind of serious condition involving tearing? Yep, esophageal tear or Mallory-Weiss tear. Very good. So with GI, gastroesophageal reflux disease, it's common, but it's not fatal. But it's important that if you do detect it, you rule out other potential causes as well. Peptic ulcer disease is another common one, and pancreatitis. If we're to think about the other causes, think about infection, inflammation, musculoskeletal, and or the weird psychosomatic stuff. Any questions thus far? All right, moving on. So this is kind of like, the basic algorithm for chest pain. So, but I guess you can do this for like any other kind of pains or acute onset kind of presentations as well. The key thing you need to know, though, with regards to a history is in chest wall syndrome and psychiatry, it's very weird, the syndrome and psychiatry syndrome. The thing about that one is chest wall syndrome is more like the sickle cell disease, right? So it's the sickle cell disease. If you want to avoid the whole biochemistry kind of pathophysiology where one amino acid gets changed from like hydrophilic to a hydrophobic one that leads to the whole sickle shape when the red blood cells, they are desaturated with oxygen. They essentially become like weird sickle/boomerang shape, if we want to use, I guess, Australian kind of analogies. And as they clump together, it obviously makes it hard for blood to go through if all those blood cells were to accumulate and clog it up. Essentially like red blood cells as opposed to clots or cholesterol, they are now clogging up the vessels. And when you clog up the vessel, that could lead to obvious ischemia. And with ischemia, you can have that sort of acute onset pain. And with regards to some of the psychiatry causes, the Costa syndrome is very weird, where you have unusually hypersensitivity to what's going on to your heart. So essentially, you are pretty much excessively aware of every heartbeat, every movement of your heart, essentially, and that kind of gives you to have this weird, not weird, but like this abnormally excessive fear that it's something worse going on, even though it's, again, touching upon the weird psychosomatic thing. All right. Hope that kind of answers that, KJ. As I was saying, with regards to the history of chest pain, you want to start off open-ended, general, and then you focus kind of towards an inverse triangle similar to the heart, where you ask more specific questions. And then once you feel that you got the general idea of what is causing that chest pain, then you go for the moneymaker, yes, no, close-ended questions to tie up whatever loose ends, connect the dots for whatever clinical constellation you want to draw. All right, so let's proceed. So now we go back to the patient who presents with the following kind of,
signs and or symptoms. So guessing nothing too out of the ordinary here. So what kind of tests or investigations would you like to order? I guess you can consider both specific and or I guess broad picture as well. I don't mind long awkward stares, but I do know that you have places to be later on tonight. So just one answer would be good. I don't care if it's right or wrong. Yeah, ECG, very good. You pretty much want to do ECG for every single type of chest pain. Sorry, I asked what type of tests or investigations would you order for this patient based on what you figured out from the history? Yep, troponins, very good. Moving on. Yep, very good, Jonas, thank you. So now these are pretty vanilla stuff, standard stuff that you would order for any kind of chest pain. If at the very least you want to err on the excess, be excessive rather than insufficient with regards to the test, because you really want to find out what is going on here with this patient. So with ECG, you look for ischemia, and that can be confirmed with ST changes, elevation or depression, T wave changes, specifically T wave inversions, or abnormal pathological Q waves. And does anybody want to remind us what ST refers to on, if you were to look at the ECG, what does ST refer to with regards to the physiology, electrophysiology of the heart? Okay, so it refers to ventricular repolarization. Oh, well, as the heart, as the ventricles recover and get ready for another contraction. So FBEs, you want to either see if there's anemia and or check for infection/inflammation. Urine electrolytes, creatinine, renal function, because if you think about it, the renal system is like connected to the cardiovascular system in series. If for those of you who did physics before, or electrophysics, I guess, and if they're connected in series, one likely affects the other. One tends to affect the other, but you also get these weird things where, so an echo can actually be done, bedside. It's because it's not invasive. You just need to kind of, wait, is it Catholic? No, it can be done in the consulting room actually. But it can be done pretty much anywhere, because it's very easy to do and it's non-invasive. So depending on whether you are on cardio consults or if you are in emerge/ICU, an echo can be done quite easily. So yeah, as I was saying, cardiovascular, renal system are connected in series and they affect each other, but it depends which affects first, or do they both occur at the same time. Liver function test, you want to make sure that it's not GI related, specifically CRP, C-reactive protein, marker for inflammation, chest x-ray to see if there is any kind of opacification, consolidation that you can see that are suggestive of pneumonia, or if there are hyper-sized lung fields, pneumothorax, or also consequences of heart failure. And the echo is not an official first-line test, but it helps to visualize the function of the heart. Valve function, ejection function,
as well as distinguishing one type of heart failure versus another, which we'll talk about later. So back to the patient again, what does this tell us? Well, there is a myocardial injury of some kind, which includes both ischemia or lack of oxygen supply to the heart. And obviously with things that are starved of nutrients, they die. In this case, lacking oxygen, lacking that aerobic respiration, necrosis of the heart. And troponin levels will increase in the bloodstream, generally for which time frame after MI? When will they become elevated? Minutes, seconds, hours, days? Right, so it's within a few hours, actually. So afterwards, it can slowly increase between the first 1 to 3 days post-MI, and that elevation can remain high for a period of up to 2 weeks. So which of these troponins, there's like a few types of troponin, but does anyone know which type is specific for cardiovascular disease or coronary heart disease? There's 3 types of troponin, C, T, and I. Which of them is cardiospecific? Yeah, it's I, very good. So troponin C, it actually initiates the whole contraction with the whole calcium binding, which in turn moves troponin I, which is the specific marker of cardiac involvement. So those two together, they pull the muscle fibers, they contract them via their interaction. Troponin T is the non-specific one that anchors the troponin complex to the muscle fiber structure, and that's the one that's more indicative of a non-cardiovascular reason for troponin injuries. So let's talk about ischemic heart disease itself. Ischemic heart disease, coronary artery disease, however you want to slice it, it's a group of pathophysiologically related syndromes that results from the actual starving of the heart, myocardial ischemia. So it can present in various ways. One is the stable angina or the acute coronary syndrome. So does anyone know kind of the one difference, like maybe the timeline difference between stable angina versus unstable angina or non-stable angina? Yep, very good. So more than 20 minutes for unstable angina for everyone out there. So to confirm it, you need ECG. You need the ECG to see if an ST is elevated, because if you're suspecting STEMI or non-STEMI, you want to see it by the ST elevations in certain leads. You would suspect unstable or non-stable angina if the actual troponin is not elevated to indicate a transient ischemia. And you would typically look at the tropes 6 hours after the initial onset of chest pain or other associated symptoms. So because our patient had acute onset STEMI, ST elevation on ECG most likely is STEMI. So any kind of questions or comments thus far? You can see an ST depression. ST depression is interesting because it's not exactly pathospecific for a heart attack or a myocardial ischemia. All it does is just indicates that there is a disruption to the electrophysiology going on at wherever that lead is located on the heart. So to better understand STEMI, we got to think about the whole arteriosclerosis clotting and dislodging of the clotting process. So with arteriosclerosis, that means just a hardening of the actual arterial vessels. But you need to know that there's a difference between, there are two distinguishes between them, which is arteriolosclerosis, so hardening of the arterioles, the small arteries in the arterioles, which is the one you is heard with the hyaline arteriolosclerosis, which high blood pressure can lead to, because with high blood pressure, that is pushing that blood, and that blood is just striking the walls of the vessel so hard, it leads to the endothelial damage of those vessels. If those vessels were to be damaged with their infrastructure, it could lead to the leakage of plasma proteins across the endothelium, as well as increased matrix production via the smooth muscle cells within the tunica media as a response to that injury, because you want to clog up that hole really darn quick. So what happens is you have this homogeneous pink, kind of smooth hyaline thickening of the actual endothelium of the arterioles, which in turn would lead to shortening of the lumen within the arterioles. And again, going back to that physics aspect, if you were to recall Poiseuille's flow law, one of the major factors that determines the flow rate of fluid, in this case blood, through a pipe, or in this case a vessel, is the actual inner radius of that pipe or that vessel, because it is related to the inverse fourth power of that radius, if I remember my physics correctly. Atherosclerosis is kind of more or less similar, except answers in the medium size or muscular, large size or elastic arteries, because you form an atheroma, essentially a plaque, a fat-based or cholesterol-based plaque within the intima of the arterial wall. And it is the most common and most clinically significant pattern in the context of arteriosclerosis leading to myocardial ischemia. So risk factors for, atherosclerosis, feel free to jot them in the chat or speak it out loud, however you're comfortable. Yeah, predisposes male more than female. Yep, smoking, because the actual chemicals damage the arteries themselves. Diabetes mellitus for sure. Diabetes mellitus, you that kind of complicates with a lot of things. And yes, of course, the actual aging process itself, because with age, the arteries become less kind of elastic. They're more hard and rigid. So with these risk factors, it all leads to the endothelial injury itself, which, if you recall, is one of the Virchow's triad. And this results in an increased uptake of low-density lipoproteins into the tunica intima. And it can be oxidized to form oxidized LDL particles. And these oxidized particles, they bind to endothelial cells, which in turn increase the expression of adhesion molecules and chemotactic factors, so essentially the sticky chemokines, sticky messengers essentially within the body. The monocytes, or the baby macrophages, will then migrate into the tunica intima and then mature into the adult macrophages. And as macrophages are known to do, they create reactive oxygen species. So those weird kind of products with like lone electrons out there that can just mess stuff up. And that contributes to further oxidation of LDL particles in this cumulative causative cycle. And these oxidized particles, they bind to scavenger receptors on the actual macrophages. And then that in turn leads them to become, the foam cells. And as foam cells, and which in turn interact with leukocytes, they form fatty streaks or lines of fat within the intima of the artery. And these foam cells, they just make all things worse, again, adding more to that cumulative causative cycle by causing smooth muscle cells to move from the tunica media, where they were originally at, into the tunica intima, so deeper into the central, sort of closer to the lumen of the arteries themselves. So they're moving from out inwards. So these foams, so what happens is then the smooth muscle cells who don't know any better, they just try to plug it, put connective tissue into the tunica intima. It changes all those layers of fat into an actual atheroma, that plaque, a lipid-centric core with a fibrous cap. And the fibrous cap in a chronic process would be more resilient and more stable. And as you know, the arteries themselves were to get more occluded over time. And if it's to be young, it would be less stable. But what is the problem for the fibrous cap to be less stable or easily to be dislodged based on what we've talked about? So you essentially have a stable, which is more of a chronic critical stenosis, I guess, if that were to lead to 50 to 70% plus occlusion of the cross-sectional area of the lumen. And the thing about chronic process is that your body tends to adapt. But if it's like relatively new, relatively presenting, the thin, unstable plaques, that's the risk of rupture, damaging the actual arteries themselves. So what do you think would happen if that cap were to rupture? Yeah, because formation of a clot and a very disturbed ECG. Because essentially what you're doing there is you're just causing a direct insult to the body. And if there's a direct insult, bleeding, and you want to clot, but one of the obvious consequences or risk of clots is that that can occlude the artery even further, and that can lead to ischemia, and that can lead into infarction. Right, so with IHD, if you were to go through this kind of clinical algorithm, it's, again, based on a few things. One is timing of the presentation, like does it go away within 20 minutes or so or not? If it doesn't, is it ST or non-ST depending on ECG? And if there are tropes or no elevated tropes, is it non-STEMI or unstable angina? So now let's talk about hemostasis. So we kind of talked about this already. So if there were to be blood loss from the vessels themselves, that because the body, whenever there's bleeding or insult, they try to repair it as soon as possible because they don't know any better and they just want to plug the hole, essentially. So with an unstable plaque rupture, hemostasis kicks in, tries to plug the hole. So if you recall, in any kind of bleeding thing from pathology lectures or whatnot, you want to narrow the arteries to reduce blood loss. And that's done by the neurogenic mechanism and by endothelin itself. And which in turns would lead to the net result of just slowing down the bleeding and just giving the clotting more time to work, essentially. So with primary hemostasis, you form a platelet plug, which in turns disrupts the endothelium that can be exposed. And by the exposed endothelium, that leads to the, what percent of stenosis leads to angina? That's a very good question. So there are various factors, but if you think about, say 50%, let's say around 50% is kind of like the smallest amount to detect it. It's usually mostly noticed on exercise for obvious reasons. As you progress to say 70 to 100% occlusion, around that time, the body could lead to forming collateral vessels in order to bypass that stenotic coronary artery so that the heart can still be perfused and stuff. So it's one of those weird paradoxical things where it's within like that 50 to 70% range that you really kind of get that chest pain. All right. So going back to primary hemostasis, when you form the platelet plug, as the endothelium gets exposed, it produces von Willebrand factor and collagen. So those are like the two kind of ingredients to promote the rest of the clotting cascade by first getting platelets to clump together. And as platelets come together, they activate, which in turn leads to the platelets that are initially rounded discs similar to erythrocytes become spiky so they can stick together better. The synthesis of thromboxane A2, which binds to the receptors of platelets, which further leads to the whole platelet coalescing together, as well as a structural conformational change within GP2B 3A, which in another term leads to a kind of fancy way of saying that it increases the platelet's affinity for kind of fibrinogen or non-activated clotting factor 1. This in turn acts as the bridge between the GP2B3A receptors on the various platelets, which in turn leads to platelet binding and aggregation. Lastly, the platelets themselves, they release granules such as ADP, so ATP minus 1 phosphate. And the ADP in turn binds to specific receptors, the P2Y12 receptors on other platelets to lead to the subsequent activation of the secondary hemostasis. So with primary hemostasis, you form the primary hemostatic plug. So with secondary hemostasis, that's when the actual coagulation cascades and the fibrin clot really happen. So it consists of the intrinsic pathway and the extrinsic pathway. So does anybody want to volunteer which of those two pathways is technically faster? So which of them? Yep, extrinsic, very good. So the reason why extrinsic is faster because it is easier to activate and because it is activated by the release of tissue factor, which is already happening. And that is already measured by prothrombin time or the international nationalized ratio. The thing with intrinsic pathway, the reason why it takes longer to fully get going is because you need more steps in clotting factors to really commit to clotting. And that is measured with the APTT, activated partial thromboplastin time. So with the next step, you narrowed down the vessels, you've engaged in both aspects of hemostasis, primary and secondary, and essentially now you form the actual clot that consists of fibrin and platelets that pretty much halts blood loss through that disrupted coronary artery. So you would think, or you would hope that everything's all hunky-dory by plugging this hole, but what actually happens now is for that clot to stabilize over time. So the clot and the plug, it contracts, gets smaller, and the TPA, tissue plasminogen activator, it changes plasminogen to plasmin. And the plasmin breaks fibrin down into the fibrin degradation products, which includes D-dimers. So D-dimers is an important clinical tool to assess risk of pulmonary embolism, DVT, because if D-dimers were to be elevated, that means like there must have been some recent clot that have occurred. Could have occurred in the lungs, could have occurred in the peripheral limbs. I don't know, but that's why D-dimers are important. So with this, for the clot to stabilize and to break down, it doesn't occur quickly. So as it breaks down, it can either partially or completely block the inside of the coronary artery, which in turn would lead to the whole starvation of the heart muscle tissue supplied by that artery in particular. So ultimate outcome, which we've been kind of discussing thus far, is the infarction, myocardial ischemia, the necrosis of the heart muscle itself. So we talked about essentially the physiology and the pathology pathogenesis of atherosclerosis leading to ischemic heart disease. But to really appreciate why clogging up this circulation, the coronary circulation, this pipeway system is significant, let's take a step back and understand the coronary supplies of the heart. So with regards to the coronary circulation, is normally right coronary or right heart dominant. So what this means is that to determine whether a heart is right dominant, co-dominant, or left dominant, you look at the right and left coronary arteries to see if they give off the posterior interventricular artery. So if the left were to give off that artery, it would be left dominant. If both of them were to give off the posterior or feed into the posterior interventricular artery, that can be co-dominant. So three main vessels that are typically occluded, and I guess important to know with regards to myocardial infarction, is the left anterior descending, which results in the anterior infarct, the right coronary artery, which leads to the inferior infarct, and the left circumflex, which leads to the lateral infarct. And if there are stenosis in all these three walls, it's known as a triple vessel disease. President Bill Clinton had 4 bypasses, so he could have, I guess, had a quadruple vessel disease, but again, it's a bit tangential to what we're learning. So how do you know which coronary artery is occluded? Well, you essentially do an ECG, because the coronary arteries themselves are functional terminal arteries of the coronary circulation. So if you talk about right coronary artery, it's most common. It supplies the SA node and replies the AV node via PDA. The left circumflex coronary artery would supply the remaining kind of cases of those with arterial occlusion. So on a 12-lead ECG, there are different surfaces of the heart. Leads 1 and leads AVL are lateral leads, which are mostly supplied by left circumflex. 2, 3 AVF, inferior leads, inferior surface of the heart, supplied by RCA. V1, V2 are the septal leads, which are mostly supplied by LAD. Leads V3 and V4 are the anteroseptal leads, mostly supplied by left anterior descending. V5, V6 are the anterolateral leads, which view the anterior surface of the LV and lateral surface of the heart, mostly supplied by LAD and left circumflex. This, a posterior STEMI. So a posterior STEMI, that would be indicated, that would usually be done kind of like a posterior ECG to really kind of confirm. It's not as common as the anterior circulation because remember the LCA and the RCA and the left circumflex, which kind of supplies the lateral front aspects, are the ones that are most commonly affected. But if you were to really want to confirm a posterior STEMI, you would really connect leads on your back as well to get a better picture of the electrical conduction towards the posterior aspect of the heart. So going back to the patient, there are hyperacute T waves and early ST elevation in leads 2, 3 AVF with a reciprocal change in AVL and leads 1. So this is an inferior infarct, most likely caused by occlusion of the RCA. But in order to really know where it is, that's where you need to go to cath lab and do the angiography. Yeah, so this is one way to determine whether it is a partial mural infarct versus a transmural infarct. If we were to remember, because when the arteries supply the heart, it goes from external to internal, from outside to in. So epicardium, then myocardium, and then subendocardium, and then endocardium. So if it were to be completely infarcted, there would be no electrical pathway that could potentially go through. Yeah. So let's start from square one. Patients come to ED after history examination investigations. There's diagnosis of an inferior STEMI. How are you going to treat it? Or does anyone know the acronym with regards to initial management of acute onset? PCI, yeah, you can do that for reperfusion. Yep. So with everything, you need to address the symptoms. So nitrates, GTN. What GTN does is it helps to venodilate the arteries. So by doing so, this reduces preload. And if you reduce preload, this results in a reduced need in oxygen demand by the heart. So that will essentially relieve the myocardial ischemia by reducing how much the heart wants that oxygen. And by reducing that demand, that ultimately leads to symptomatic relief of chest pain. The only time you don't want to give nitrates is Viagra, or patients that use Viagra for ED, erectile dysfunction. So normally with CGMP for inferior STEMI, I honestly don't know. I probably have to read up about that, but that's an interesting thought. But as I said, contraindicated for those with erectile dysfunction. You also want to provide morphine and fentanyl, as they are opioid agonists, which provides an analgesic effect. Obviously, though, you would be very careful to deliver morphine and fentanyl because of the obvious drug addiction that could potentially occur. So this is why they require kind of constant monitoring and or adjustment, such as in ICU. Lastly, oxygen, because you want to supply that oxygen for the parts of the body, in this case the heart, that is kind of starved for oxygen. But again, you gotta be careful with oxygen therapy, because oxygen, like other things, is a drug. So there's essentially three principles with regards to following symptom management, addressing the clot itself, in this case in the right coronary artery. So you want to prevent the actual primary hemostasis, so that precursor step to the clotting cascade to occur, by interfering with the platelets coagulating together and sending signals. Also, you want to make sure that the secondary hemostasis doesn't occur by actually interfering with the clotting factors themselves that are a bit downstream in the clotting cascade. And you want to carefully break up the clot or dissolve it using fibrinolytics. So with primary hemostasis, antiplatelets. So what types of antiplatelet therapy exist, or what kind of drug would you give to prevent primary hemostasis? Yep, antiplatelets, but which one specifically? Remember, it's dual antiplatelet therapy, so there are two drugs. What's the common one that begins with A? Yep, aspirin. Thank you very much. Clopidogrel is also a good one as well, but let's move on. So to understand how aspirin works, you got to think about the arachidonic acid pathway. So what it does is it's a COX inhibitor, so cyclin oxygenase inhibitor, which is like responsible for the whole, I guess, inflammation pathway layer downstream. So with aspirin, what it does is it blocks the COX from converting the arachidonic acid into PGG2, PGH2, which will otherwise lead to the whole thromboxane clotting kind of cascade to occur. You got to be careful though, because with aspirin, it's irreversible COX inhibitor. So obviously, if something's irreversible, it's very difficult to reverse it, especially in the case of an aspirin overdose. And there's also the risk factors of increased GI bleeds as well. And basically, the net effect is with irreversible COX inhibitors, the nucleus itself is biochemically blocked. So you can't do the whole biochemical dogma of transcription, translation to protein synthesis. This one in turn leads to vasodilation and inhibition of platelets clumping together and leading to that whole clotting cascade. So another thing to talk about with regards to dual antiplatelet therapy is PTY12 inhibitors, which is one of the receptors on the platelets, if you recall. And so that's the one where clopidogrel is involved. Because clopidogrel is a PTY12 inhibitor, and essentially what it does, it prevents ADP to lead to the receptor to initiate that platelet activation and the sequelae of events from that platelet activation. There's also GP2B3A inhibitors, which is that fancy receptor that leads to the stabilization of the fibrinogen, the fibrin kind of mesh, or that mesh, so to speak. So preventing the secondary hemostasis, anticoagulation is used, which can be classified into oral anticoags, NOACs, or parenteral anticoagulations, which is administered via injection/IV drip. Oral anticoagulations is used more long-term, whereas the injections, the parenteral drips, or parenteral injections or the infusions are used more short-term within hospital. So with oral anticoagulations, what are the two genotypes? Does anyone know? Or how they work? So one of them is warfarin, which inhibits Be careful when you say it's a vitamin K inhibitor. It actually inhibits the enzyme depending on vitamin K, the vitamin K epoxide reductase, which in turn activates the actual vitamin K. Vitamin K is important for clotting factors, making clotting factors 2, 7, 9, and 10 for the gamma carboxylation for activation. And to closely monitor the effects of warfarin to make sure it's not going too ham, so to speak, you look at PT, prothrombin time, because that is tied in with the extrinsic pathway, the fast pathway, so to speak. And NOACs or DOACs, so the novel oral anticoagulants, are the sabans, the apixabans, rivaroxabans, and as the name implies, it bans or inhibits X or clotting factor 10, the common clotting factor in the coagulation cascade. And with the more direct kind of bioavailability solutions via parenteral or IV, you would give heparin. So unfractionated heparin, which activates antithrombin 3, while inhibiting thrombin 2, and by inhibiting clotting factor 2 and activated factor 10, as well as low molecular weight heparin, which is only specific for activated factor 10 and not thrombin. And this is the one that's more suited for self-administration at home. And just like how prothrombin time monitors warfarin, activated partial thromboplastin time, or APTT, monitors heparin activity. So in cath lab, there's the reperfusion therapy. I'm not sure if they will actually assess you on the specifics of using the interventional cardiology stuff via perfusion therapy, but the long and short of it is, one, they use a combination of peripheral of PCI, which is a catheter inserted via usually a radial artery, though it used to be femoral, but radial is preferable for less risk of complications. So you would rather do PCI first. You'd rather do PCI first rather than fibrinolytics. You would ideally want to do not just PCI first, but as the only thing. So with PCI, enter the artery, guided under CT, go through the clot, inflate the balloon to smash the clot, to reduce the obstruction, and then you put in or expand the stent. So you similarly, it's like a net that kind of opens up and pushes against to ensure patency of the artery. And fibrinolytics, essentially what they do is they simulate TPA, tissue plasminogen activator, which, as you remember, naturally occurs in the body to control clotting, to break down or resorb the clot. So it resorbs plasminogen, it converts plasminogen into plasmin, breaks fibrin into the degradation products and D-dimers. So here is a summary of all the management thus far. So the whole MONA-R, so morphine, oxygen, nitrates, analgesia or aspirin. Well, morphine is, and R is reperfusion. So MONA-R. There is something in the literature that kind of contraindicates MONA-R or says outdated, but essentially most of it still applies. You just need to ensure that there's the R aspect to it because you need to obviously reperfuse and not just treat the symptom. So now, as the hotshot junior doctor that you are, you took the history, you did the examinations, you did all the tests, you did all the management with regards to symptom management and reperfusion. So now the patient's symptoms have resolved and he's now stable and likely ready to be discharged after some final consultations with either the general physician and or cardiologist. But obviously we need to think more intermediate long term. So obviously, one, ensure that the patient doesn't put himself at risk for another myocardial infarction, and two, to ensure that he lives as long as possible with the highest quality of life. So you would continue with the antiplatelet therapy, so aspirin plus clopidogrel, for about a year after an infarction like this. After this, and following a review, maybe with the cardiologist, you can stop the clopidogrel. Statins is to be taken lifelong because you really want to make sure you don't get that cholesterol up to cause another clot to happen. Last but not least, beta blockers, at least during hospital admission, and ideally cardio-specific beta-1 blockers, atenolol, because it specifically acts on the SA node itself and the heart muscle to be negatively chronotropic, decrease heart rate, and also negatively inotropic, so decrease heart contractility. You would also do ACE inhibitors within the first day or two, 24, 48 hours of myocardial infarction, and obviously the various things to improve lifestyle modifications of pharmacotherapy, such as educating them about the risk of ACE inhibitors leading to coughs and stopping smoking if they haven't done so already. So if you go back to the patient, if they were diagnosed with high blood pressure, why is that such a big risk? So in the literature, and obviously for what we discussed about high blood pressure flow that pushes against the walls and likely leading to damaging the actual endothelium, there is a continuous relationship between blood pressure and absolute cardiovascular disease risk. So it's linearly related. One goes up, the other goes up. So there is actually no minimal, or there's no like minimum threshold to reach. It's going to be a risk regardless. It's linearly related. So if you were to have a patient that runs into your consulting room, measure the patient's blood pressure to be, say, 160 over 100, and you know hypertension is the arbitrary threshold of higher than 140 or 90 or 130 over 90, depending on which system you go. Do you think that's hypertension off the bat? Or would that be sufficient to diagnose this patient with high blood pressure? So this patient comes in running all distress and stuff, saying 160 over 100. Okay, normally, I guess if you think if it's 160 over 100, especially if you were to measure it again, especially lying versus standing, you can say, yeah, it's like hypertension, probably borderline malignant hypertension. But in terms of the realistic setting, you can't use one clinical or one ED blood pressure measurement alone to clinically diagnose a person with blood pressure. You need to take into account various things. So did the patient run into the GP? Was the patient physically exercised beforehand? Did the patient have any kind of coffees, or did they smoke? Did the patient have white coat syndrome? Did the cuff size, was it appropriate for the patient's arm length, or was it too small or too big? So after standardizing something and taking 2 blood pressure managements on separate visits, ideally 1 week apart, without a shadow of a doubt, then you can consider doing some 24-hour ambulatory blood pressure monitoring to confirm it is indeed clinical hypertension. So with regards to antihypertensives, what are some of the drugs that you recall? Do you remember? Or do you know of any? Yep. ACE inhibitors, adrenal receptor beta blockers, calcium channels, yep. Very good. The OLOLs. Out of those that I mentioned that people just typed in, beta blockers, calcium channel, ACE, or ARBs, which of them is not first line? Yep, beta blockers. Because in patients with uncomplicated increased blood pressure, they are less effective than the first line drugs, so the ACDs, so to speak, in reducing risk of strokes or other kind of vascular events. But you would consider them in helping patients with heart failure with reduced ejection fraction and coronary heart disease. So this is all kind of like the treatment algorithms with regards to the pharmacological management and stuff, which you can explore further after I distribute the slides. And now dyslipidemia. Now it's another kind of risk factor here. Why is this important? So yeah, that's why you need statins. Yeah. So as we mentioned about clots, and if we're talking about these kind of extra manifestations of cholesterol or lipids, they're kind of like Shakira's hips. They don't lie. Like clearly this patient have some metabolic issues or some issues with regards to their cholesterol lipid metabolism, i.e. is abnormally high. So aside from these deposits, they may not present with any specific signs or symptoms, but that's why you would look for these on a more tailored cardiac exam in the peripheries, in the joints around the eyes. And it's diagnosed as a blood test of high cholesterol, so total cholesterol, high TGLs, triglycerides, and reduced HDL. Another thing you can look at is the HDL-LDL ratio as well. So statins, pretty much first line, HMG-CoA reductase inhibitors. This is pretty much long life for the rest of their lives, post-event, unless they are significantly intolerant of the statins, then you may consider other alternatives such as ezetimibe or PCSK9 inhibitors or the resins or fibrates. So ezetimibe, it inhibits NPC1L1, which is at the small intestine brush border that is responsible for transporting cholesterol across the intestinal cells into the bloodstream. The PCSK9 inhibitors are essentially antibodies that inhibit the PCSK9 enzymes. So what this does, it prevents the actual LDL receptor itself, because LDL is to transport for cholesterol and lipids across the body. It prevents a conformational change so that the LDL receptors become redirected to lysosome. Bile acid resin, it just prevents gut reabsorption of cholesterol because the gut tries to reabsorb all nutrients. Fibrates is a nuclear receptor agonist that increases the production of lipoproteins, and with more lipoproteins, that helps to break down triglycerides. But in turn, that also helps to increase the level of HDL. Its effect on LDL kind of varies. And with vitamin B3 or nicotinic acid, it's very rarely used because, but what it does, it inhibits hormone-sensitive lipase, normally responsible for lipolysis in adipose tissue. It also can affect VLDL synthesis in the liver as well. So now you think everything's all hunky-dory after you looked after the patient and you took care of intermediate long-term management, but now they present with this. So what could possibly be going on? Yeah, heart failure in general. So
With triglycerides are primarily elevated, do you trust statins or go straight to, it could be a DVT, you're not wrong, but it would most likely be heart failure. But to answer what was just asked, if triglycerides are primarily elevated, you kind of just, if it's the only thing that's elevated, you would try to advise them to watch their lifestyle, monitor that first. Because you want to try to put them as minimal drugs as possible. But if they already have an MI, you would still go for statins. You would still want them, you don't want to say just statins and that's it, it's a magic pill. You need to encourage the patient to adopt a healthier lifestyle with lifestyle modifications as well. And you want to put them as few drugs as possible. So these are the list of possible complications that could happen: arrhythmias, pericarditis, myocardial rupture, aneurysms, or LV heart failure, as one I mentioned below, as one I mentioned earlier. And yes, of course, it's really hard for them to change their lifestyle. So I guess that this is something that would involve multidisciplinary discussions. Something that you, at least for those of you who are in the Melbourne Medical School, may have discussed in professional practice or clinical skills tutorials. That you can't just tell them to quit smoking. You can't just tell them to lose weight. You can't just tell them to exercise. This is going to require some ongoing management and follow-up, because drugs are there to support, but it's never the magic bullet as people like to believe. All right. So now if we were to focus on heart failure, it's a clinical syndrome, which means like obviously the heart literally fails to do its job. It could be the right heart that's affected. It could be the left heart or left ventricle that's affected, or it could be all of it that's affected. If we're talking about left ventricular or left heart failure, it's pulling up back blood from left ventricles into the left atrium. It leads then up into the pulmonary vasculature, which would result in the pulmonary edema, which can present as shortness of breath, waking up with shortness of breath, and paroxysmal nocturnal dyspnea, as well as requiring multiple pillows in order to redistribute that thoracic accumulated fluid so that they can sleep better. So now with right heart failure, which can occur secondary to left heart failure, or maybe due to something else, like something affecting the liver, this leads to a congestion or backing up of blood from the right ventricle into the right atrium. This can present clinically with an elevated JVP. I've seen some JVPs raised on patients up to their earlobes on the right side of their body. It can also lead to everything downstream of the inferior vena cava, which leads into the hepatic vein, which leads to hepatomegaly. So an enlarged liver if you're to do an abdominal palpation. And even further downstream or further inferior to that, peripheral edema. If you were to think about clinical practice though, congestive cardiac failure or biventricular failure, that presents with both aspects of the shortness of breath as well as the excess fluid buildup, such as fatigue and weakness. All right, thank you, Dr. Victor Lin. And sorry, we're going into the final stretch here. We're almost done. So cardiovascular exam, you really want to focus to make sure, like, are they on ECG? Are they Holter monitoring? Are they on some oxygen supplements? Are they on, do you see any kind of nearby kind of medications on their desks and stuff? Don't miss out on stuff that are otherwise obvious. Want to make sure the following steps. Make sure apex beat is not displaced. When you're more experienced, you might be able to feel for heaves, which is like right ventricular heaves. So you can actually feel the right enlarged right ventricles pumping against the back of your hand like this. You may be able to palpate thrills, which is like if you're able to palpate murmurs at those spots where the valves are here. And also when you auscultate, ideally try to auscultate on bare skin.
and not through clothes. But obviously, if the patient can't get out of bed or out of the chair, then you'll make do with what you have. So in summary, think about elevated troponins, particularly troponin I, if it's cardiovascular involved. This is kind of like the recap of the case, in case I didn't make that clear. Leads 2, 3, and AVF are the inferior leads, which suggests a right coronary arterial occlusion leading to infarction. Leads 1, AVL, are lateral leads, which suggests left circumflex, as well as V5, V6, which are more anterolateral. You would consider dual antiplatelets, aspirin and clopidogrel, as well as GP2B3A inhibitors to prevent primary hemostasis. You also want aspirin as well to inhibit the whole arachidonic acid pathway, leading to thromboxane. You would use the oral anticoagulants, so either the warfarin or the NOACs for long-term use, parenteral IV heparin, unfractionated or subcutaneous low molecular weight heparin to consider in hospital or short-term use. And vitamin K warfarin affects the vitamin K clotting cascades 2, 7, and 9, and 10. So with regards to reperfusion therapies, it's the PCI, the catheter, the fibrinolytics. You want to avoid GTN in ED because of the whole massive vasodilation. So it's like a synergy, so it's like a combined effect. And with regards to lipid levels, you kind of want to prioritize HDL to be high, so higher than 1 millimoles per liter, LDL to be less than 2 millimoles per liter, or less than 1.8 if the patient already has cardiovascular disease at the time. You want triglycerides to be less than 2, and you want total cholesterol to be less than 4. Depending on the cardiologist, I've had a cardiologist who was okay with an LDL to be just sitting right at 2, but it has been 2 for like months for that patient. So as long as it doesn't increase at all, it depends. And which lipid modifying drug has the biggest effect on triglycerides? As one mentioned, fibrates. So if patients are struggling to reduce weight, then I guess you can start giving them fibrates in addition to their statins. But again, discuss with a pharmacologist as well as a cardiologist to prevent kind of the potential side effects and stuff. You don't have to memorize those specific drugs, but just know that you want to reduce cholesterol levels, particularly in patients post-MI. So we talked about kind of ECG earlier, but it's essentially, it can be done at bedside. It can be done in, it's non-invasive. It looks at the electrical physiology of the heart. So you want the patient to be kind of semi-upright or semi-sitting, semi-recumbent. And you want to make sure that it's not too hairy, it's not too oily. So you got to shave and wipe that down if necessary. So even though it says a 12-lead ECG, it's technically 10 electrodes. So 6 precordial around the heart and 4 limbs, or 3 depending on the system. You place V1 in the 4th intercostal space, right sternal border, V2 in the 4th intercostal space, left sternal border, V4 in the 5th intercostal space, midclavicular line, or the apex of the heart, V3 halfway between V2 and V4, V5 in the left anterior axillary line on the same horizontal plane as V4, V6 on the left mid-axillary line on the same horizontal plane as V4 and V5. Place RA right arm on the inner wrist of the right arm, left LA on left arm. Sometimes you can have both right leg and left leg or just one of the left legs. Essentially, you just need to have at least one leg lead. So long story short, you essentially get a net electrical vectors to produce the ECGs. And now to measure blood pressure, ideally you need to train, at least on the wards, to learn how to do it manually. But if not, then you can see some automatic ones that could be in consult's office, or you can see also patient being monitored as well, especially on the cardiac ward or on CCU or ICU. Remember when discussing blood pressure that if it's persistently high, even if you were to take away the coffee, take away the exercise, take away the smoking, it's established independent risk factor, linear risk factor for cardiovascular disease. So if you want to do absolute cardiovascular disease risk, not for adults younger than 45 years of age without no cardiovascular disease, but we do so for anyone 45 years or higher or older. These also take into account smoking status, cholesterol, dyslipidemia, if they have it, history of diabetes / metabolic syndrome, if there's evidence of left ventricular enlargement on X-ray or ECG or echo. So with regards to high blood pressure, most of it is essential high blood pressure because essentially you don't know exactly what's causing it. And 5% is secondary to something else, some renal issue, some metabolic or endocrine imbalance, or some suprarenal or the adrenal gland issues. Cushing's syndrome is just increased stress cortisol, is essentially increased glucocorticoids, which would lead to the whole moon phases, the hump on the neck, and it just causes increased release of ACTH, which in turn leads to increased cortisol release. Cushing's disease, on the other hand, is a pituitary adenoma that releases the ACTH. It can also be a result of small cell lung cancer, so ectopic ACTH syndrome as well. Primary aldosteronism or adrenomedullary chromaffin cell tumor or pheochromocytoma, essentially excess aldosterones or mineralocorticoids or increased adrenaline noradrenaline leads to increased blood pressure. This is the whole blood pressure regulation, which you can study later. This is how the body normally regulates blood pressure. So it involves various systems in the brain, in the heart itself, in the vasculature, especially the kidneys, which will be explored later in the third lecture series. With cholesterol, this is the whole cholesterol metabolism, which may have been covered by Professor Salhoun in her lectures. But essentially, if you understand this, you understand how statins work by inhibiting HMG-CoA reductase, as well as the other drugs, how they work as well. And TLDR, you want HDL to be as high as possible, LDL to be as low as possible, but at the same time, you also want total cholesterol to be as not as minimal as possible as well. With regards to heart failure, there's reduced ejection fraction or systolic versus preserved ejection fraction. So with reduced ejection fraction, the ventricles themselves, they can't contract normally. And with preserved ejection fraction, the ventricles are okay, but it's more an issue to the structure of the heart itself. So it could be due to hypertrophy, it could be due to pericarditis, tamponade, or cardiomyopathy as well. So management of these includes fluid restriction in case they're fluid overloaded. You also want to do a psych review to make sure they're not depressed. Obesity management to have them lose as much weight as possible, as well as also reduce the risk of a osteoarthritis as well. Dietary changes. Drugs, if you want to support. Diuretics to, again, address fluid overload. ACE inhibitors, beta blockers to reduce blood pressure by acting on the negative chronotrope and negative inotropes. Spironolactone as well as necessary. So it's a combination of antihypertensives, also antiarrhythmics if necessary, and diuretics to control the effects of heart failure. In terms of myocardial infarction over time, you may be asked a question about the pathology of the heart. Yeah, no worries. You may be asked, like, remember, within the first few hours, there's already elevated troponin, but in terms of what you can see pathologically, there's already going to be necrosis. Time is heart in this case. So within minutes, already irreversible damage. Within hours, troponin release, particularly troponin C if the heart is definitely involved. The overall inflammatory process due to the ischemic-induced damages to the heart. The immune system kind of damage control in the form of acute inflammation, granulation, macrophages, and scar tissue, which in turn will present with the disruption in electrocardiac activity. So that is the conclusion of this lecture. I apologize for going over time as there was quite a bit, but for those I didn't have time to go in depth, there are notes within the presentations to elaborate further. But thank you so much for the attending the first lecture. For any kind of errors I may have made when presenting this lecture, I apologize in advance. And also, if you're interested, please join us for additional events, such as Dr. Lin's General Ward's virtual ward round tomorrow evening, as well as Jason Dong's Approach to Arrhythmia A3 tutorial this Saturday. Thank you so much and have a pleasant rest of the evening.